He's a world-renowned oral surgeon, very well known in Italy. He's an adjunct professor in Milan and runs the Clinica Cardarelli for his private practice. And he's joining us today to discuss the latest innovations in Exodontia. And he's also a faculty member of the International Extraction Academy. So welcome today. Thank you for joining us.
Good morning, everyone, and thanks, Doctor, for having me today. Thank you very much. Despite the critical situation about coronavirus in Italy and around the world, I'm glad to share some time with all of you talking about the latest innovation in Exodontia. It's a great pleasure for me, and thanks for the invitation.
Yes, thank you so much for joining us. Our audience will welcome this very well. And maybe we can touch up on the coronavirus as well later in the podcast, because today I'm doing another podcast with an expert on this topic. Every group or page that you go on, this is all being heavily covered. So maybe we can get some information from you as well. I've seen some videos you've posted. You're informing a lot of people. The situation in Italy is critical, right?
Yeah, it's very, very critical. Many cases of death, especially in the north of Italy. So I'd like to spend few words about the correct protocol to follow in order to take care of our patient in our practice. And I made a short video, and if you want, you can find the full video on my Facebook profile or LinkedIn profile. In this moment is very, very important.
So Italy has been really affected. You guys have been really well affected outside of China and Iran and some of these other countries, South Korea.
Yeah.
Very good. We'll get to that as well. But that's good, a good lecture material for anyone involved in surgery anyway, because we have to do universal precautions and all of those things. So, Doc, you're known for piezoelectric surgeries. It's your contention that they are less invasive. We started the Extraction Academy about 6 years ago, and I've noticed a lot of philosophies still change till today. As you know, maybe the high-speed handpiece came out in the late 60s, early 70s, so things are still new. And there's constant innovation. I've seen something like the Bennett technique. And what is your take on the newest innovations? I mean, I've spoken to Dr. Wiedemann and other faculty members of ours, and New York University came to a consensus, for example, for procedures like coronectomies.
Yeah.
And they've done a lot of research and back and forth, and it's their belief that if you remove all of the enamel during your coronectomies on the third molars, that you're in a good position to leave the roots there. What is it? Are you a guy that wants everything out, or are you a guy that will leave the roots in a coronectomy type situation, or when you get close to anatomical landmarks?
I know the coronectomy procedure, but in Italy and I think also in Europe is not most common as a procedure. In my personal practice, I always remove the roots, also when we have a close contact with the alveolar nerve, for example. And in this case, the use of the piezoelectric device, it's possible using this device to reduce the injury of the nerve. So also in this extreme case, when we have a very close contact between the roots and the alveolar nerve, it's possible to avoid the injury using the piezoelectric device, because the piezoelectric device has many advantages. For example, micrometric cut is very, very important, because with the micrometric cut, it's possible to reduce the ostectomy. And if I have the possibility to reduce the ostectomy, it's possible to reduce the edema, the swelling, and the pain. Another advantage of the piezoelectric device is the possibility to work without bleeding, because using the irrigation, using the saline irrigation, it's possible to reduce the bleeding during the procedure to obtain a very good surgical view. And another advantage is the selective cut. For example, in the particular anatomical site, like maxillary sinus in the upper jaw, it's possible to use it, for example, also in the implant surgery to prepare the implant site to preserve the sinus membrane. Also, for example, in the mandible, when we have a reduce of the bone, it's possible to prepare, for example, the implant site using the piezosurgery insert to avoid the injury of the alveolar nerve. So with this new approach, it's possible to obtain many advantages. Only one disadvantage using the piezoelectric device is the duration of the surgery, because using the piezosurgery, the time of the operatory time is longer than use the straight and piece, but is longer, but we have many advantage. In fact,
Yeah, I was going to ask you about the length of the procedure. That's probably your biggest disadvantage versus conventional drilling and sectioning. So, are you proposing that the sectioning of the teeth occur in the same manner as we would say with the surgical burr?
yeah, for the cut of the crown, I use always the straightened piece of the turbine with the drills. I never use the piezo for cut the crown, because I think it's not necessary to obtain an advantage using the piezo for the cut of the crown. So I use the piezo for the ostectomy, for remove the roots, but for the cut, for the odontotomy, I use always the straightened piece or the turbine, like
Right.
traditional technique. I think is the best solution. This is the complementary technique: straightened piece and the turbine to cut the crown, and the piezo to continue the surgery. This is the complementary approach, because I think every technique has advantage and disadvantage. So it's very important to use both technique.
Excellent. The piezo works really good also with sinus lifts and lateral windows and those type of things as well. It's a good technology. How did you get involved? How long have you been involved with piezo? How long have you been using it?
Yeah. Also for the sinus lift, for example, especially in the latest period, I reduce the lateral window for sinus lift, because I introduced the new approach, minimal invasive approach, also for increased 5 or 4 millimeter. I use the crystal approach, and using the piezo surgery, it's possible to use the crystal approach to increase 4-5 millimeter also.
That's exciting.
Instead to use the lateral window, especially in patient with a particular systemic disease. So I think this technique is very important, especially in the patient with a particular disease like diabetes, high blood pressure, and disease about the coagulation. So it's very important, the minimal invasive approach, I think.
What is yours? Okay, how long have you been using the piezo yourself? How many surgeries have you done with it? Estimate.
I use piezo from 10 years. 10 years.
10 years. Wow.
Yeah.
So your success rate is pretty consistent?
I think I buy the first piezo in Italy, the new piezo. I buy the first piezo in Italy available 10 years ago.
Wow.
Yeah.
That's wow. So 10 years of a track record, and you're pretty consistent with your results?
Yeah. Yeah.
So that's exciting. What would you say about the heat generation?
Regeneration?
Heat generation, the amount of heat that you get when you're for example, look at the magnetic mallet. You're familiar with the magnetic mallet?
Yeah, I use in few cases magnetic mallet, but this is a very good approach. For example, also for the extraction, to reduce especially in case of the ankylosis roots, is very good approach, the magnetic mallet, I think. Also for the sinus crystal approach, yes. Also
yes,
the
sinus crystal approach.
Yeah,
That's probably what. Also, it's a product coming out of Italy, correct?
yeah. In Italy, the magnetic mallet. They use many oral surgeons use the magnetic mallet in Italy. Yes, and also the piezo, because the ideatore piezo is the Italian dentist.
That's excellent. So what would you prefer to use in a crestal approach, the mallet or the piezo?
I think in both cases it's possible to achieve a good result. But in my hands, in my practice, I have more experience with the piezo. So in my hands, I prefer use the piezo. But I think the result is similar. The magnetic mallet is a very good solution. But I use it in few cases. I haven't good experience about the magnetic mallet.
I see. So particularly, I've used the magnetic mallet and I've used piezo both. Just the thing with the magnetic mallet is patients often don't like to be hammered on, you know? That's another situation that you have to deal with. They don't like the hammering motion, but it works really well for a lot of, even for implant placement.
Yeah. Do you use also for implant placement the magnetic mallet?
Sometimes in certain, if I have a good thick ridge, if you have a nice thick ridge, it's very easy to drive it in, especially like D3 bone, maybe D2 bone. It works pretty good.
Yeah. Also for the expansion of the crest in narrow ridge, is very good the use of the magnetic mallet to expand the crest in case of the narrow ridge.
Correct.
Yeah.
So magnetic mallet, piezo, any other innovations that you can think of that might be exciting? Well, there's one topic I want to talk to you about also, PET, partial extraction therapy. What is your, are you familiar with the partial, it used to be called the socket shield technique, and then it was,
Yeah, I think about the socket shield. I never use socket shield because I think the goal of the socket shield is to obtain to conserve the bundle bone and the aesthetic, especially in case of the anterior side. For example, the young patient in aesthetic zone. So using the partial extraction of the socket shield, it's possible to preserve the bundle bone. But I think in my practice, I never use socket shield because I prefer remove the roots because I don't believe in the healing of the roots around the implant in a long-term survival. So I I haven't many study about the healing and the result about the osseointegration between the implants, the bone, and the roots. So in my practice, I prefer remove the roots, place the implant with the palatal approach, and if I have 3 millimeter, more 10 millimeter, I fill the gap with the heterolog bone, only for the aesthetic result, because I think it's very important to fill the volume between the vestibular surface of the implant and the bundle bone to maintain the volume. So I use the heterolog bone only for the aesthetical result. But I think also socket shield, it's possible to obtain with the socket shield a good result. But I never use. I use a traditional technique. I remove the roots, and with the palatal approach, I place the implant. This is my traditional technique, and I think is the good technique.
that's good. But some people believe that you could preserve your buccal bone if you have a situation where you have quite a bit of atrophy, but you're also an expert on atrophied bone. You've been doing a lot of implants in that type of scenario. Can you give us more information about that?
Yeah. Also, in the implant procedure I think is very important actually, because the average of life is high in the latest year. So we have a lot of patients with atrophic bone in the maxilla and in the mandible. And frequently we have a patient with some systemic disease. So it's very important to reduce the morbidity, to reduce the invasivity of our treatment. So according to, it's possible reduce the invasivity to use a minimal invasive approach, using only basal bone, without bone regeneration, using tilted implants, for example, like All-on-4, but not only All-on-4, but using a reduced number of implants. So I use only basal bone of the patient. For example, in the maxilla, I use the very long implants to obtain a good primary stability, to avoid the sinus lift, to avoid the maxillary sinus. And in the mandible, I use, for example, 4 implants, 2 anterior implants and 2 posterior implants, tilted implant, to avoid the emergence of the alveolar nerve. Because the goal is to place the implant in very high quality bone. And in the mandible, the very high quality zone is the anterior side, and the maxilla also the anterior side, because the quality of the bone in the posterior area is low quality. So I prefer use very long implants to obtain a good primary stability in very high density bone, in very good quality bone, then use many implants also in the posterior area where the quality is lower. So with this approach, it's possible to treat also extreme atrophy, and also it's possible to do in 99% of cases in medial loading. So it's very important this approach, because I think the medial loading is the best solution to achieve the osseointegration. So if possible to do medial loading is better, because the medial loading, with the medial loading, it's possible to obtain a good osseointegration of the implants. So it's very important to use the basal bone, the immediate loading, with the immediate static and immediate function, also in extreme case. In young patients, I prefer use the bone regeneration, for example, maxillary sinus lift, or the heterolog bone, or the autolog bone, because the gold standard is autolog bone. So in young patients, I prefer use the guide bone regeneration, like 3D bone regeneration, like Curie technique. I think is the Curie technique is the very, very good solution, especially in young patients, to increase the volume of the bone and after place the implant. So it's very important to have different technique according to different patients, according to the systemic disease of the patient, the age of the patient, to reduce the biological and also the economical cost.
Excellent. So where do you actually exactly place the implants? The exact location. Let's say you have an all-on-4 situation, posterior bone missing, sinus is pneumatized.
In all-on-4 procedure?
For example, let's say you have a case with the sinus completely down, you got no bone back there bilaterally.
Yeah.
What is your approach? How do you place it?
In patient with periodontal disease, without bone in the posterior area, without also the sinusitis, in this patient, after CBCT reconstruction, I studied the bone shape, and after I planning my surgery. In this case, I prefer use only, for example, in the mandible, only for implants. In the maxilla, when it's possible, I prefer using also 6 implants, but only for implant, it's a good solution. but it's very important to follow the protocol, because in the maxilla is very, very important to use in the posterior area a very long implant, because only using a very long implant in the posterior area, it's possible to obtain a good primary stability, and is very important. In the anterior area, it's possible to place the implant about, for example, 30 millimeter, but in the posterior area, frequently I use the implant about 18 millimeter until 20 millimeter of length to obtain a good primary stability. And it's very important to start to place the posterior implant, because if I place before the anterior implant, it's not possible to change the position of the posterior implant. So following the correct protocol for about tilted implant, it's very important to start to place the posterior implant. After I place the posterior implant, it's possible to go on and place the anterior implants. This is the correct protocol. And in 99% of cases, it's possible to do immediate loading, and it's very, very important to increase the osseointegration in the next months after the surgery. In the mandible is different, because it's possible to use the long implant in the posterior area, and the short implant also in the anterior area to reduce the cantilever in the posterior area. And also in the mandible, it is necessary to start with the tilted implants and after the anterior implant. But in the mandible, it's not necessary to obtain the bicorticalism.
Excellent.
Then it's necessary to obtain the bicorticalism in the maxilla. Instead, in the mandible, it's not necessary to obtain the bicorticalism. This is the different approach. But the protocol is the same in the maxilla and in the mandible.
That's very interesting. Where can our viewers find some information about this? More about your technique and what you're recommending. Do you have a particular site or a link?
LinkedIn or in my Facebook profile, DDS Oral Surgeon, because I made many articles about the immediate loading with a reduced number of implants, because this is my best topic, not also impacted it, but also the rehabilitation of the atrophic jaws. I have many, many cases. This is my best topic. So we have, it's possible to have many information about this approach, about many video, many article, many publication, and it's possible to find in my profile, LinkedIn or Facebook.
Excellent, excellent. Wow, so that's a lot of coverage. It's good to get your take on it, because everybody has got a little different of a approach to the same procedure. It's quite interesting the way you're doing things. So tell me a little bit more about your practice. What do you like to do? Are you just getting referrals for implants and wisdom teeth, or are you doing other procedures as well?
Yeah, in my clinic, I have a dedicated operating room, and I do especially oral surgeon about impacted teeth, but also, for example, orthodontic surgical recover, also in the very young patient. And is very important in this type of surgery. In fact, in my clinic, I always do the conscious sedation during this surgery. I think it's very important the use of the conscious sedation, for example, in case of the extreme atrophy rehabilitation, also in case of extreme case of impacted teeth, because using the conscious sedation is possible to obtain a good compliance by the patient. and reduce the anxiety. And is very, very important, especially when the surgery is longer. So it's very important to reduce also the bleeding, the high blood pressure. So it's very important, this approach. In fact, in my clinic, during this surgery, I use always the conscious sedation to reduce the anxiety by the patient. And also I do oral surgery and also the implant prosthetic procedure, not only surgery, but also the prosthetic procedure, because I
Hang on
think
that conscious sedation. I got some questions for you on that. Are you using a pill, or are you using what are you putting them under?
I have my colleague that use the drugs in the muscle, non pills, but in the muscle, with the injection in the muscle, and I do the conscious sedation. And it's very important, especially in the case of impacted disc, to reduce the post-op edema, the injection of the cortisone before the surgery and immediately after the surgery. 4 milligram before the surgery and 4 milligram immediately after the surgery. And using this protocol, it's possible to reduce the edema post-op.
That's excellent.
So this is the advantage of the use the conscious sedation. It's very, very important, especially, for example, during medial loading, because the procedure of the medial loading is longer. So the patient, I start the surgery, for example, at 9 o'clock in the morning, and I do the prosthetic, the provisional prosthetic rehabilitation at the one in the afternoon, for example, at 2 p.m. for example. So when is longer the surgery and the prosthetic procedure, is very important to reduce the anxiety, to increase the compliance of the patient.
Excellent.
And another aspect very important is the prosthetic approach, because I think it's very important not only place the implant in the bone, but it's very important to place the implant to follow the correct position for the final prosthetic rehabilitation. So it's very important the correct position of the implant and the management of the soft tissue, especially, for example, in case of the atrophic jaw, because if I have a sufficient keratinized tissue around the implant, it's not possible to obtain a long-term survival. So at the same time, during the surgery, it's very important at the same time to place the implant and when it's possible, the management of the soft tissue to increase the keratinized tissue, because it's very, very important for the final prosthetic result, for the aesthetic final result, but also for the survival of our implants. So I think it's very important, because frequently I see that the implants are in the bone, but in the wrong position. So if the position of the implant is wrong, it's not possible to obtain a long-term survival, and it's not possible to obtain a very good aesthetic result, because our goal is also the final prosthetic result. It's very, very important, especially in very young patients.
Wow, excellent. So, what is your take on a hot topic? Is complications management here in the U.S. I mean, we all know how to do extractions, simple extractions, but when things get a little bit bloody, and we're not using things like a piezo, our situation is quite a bit different. So, what do you say to cases where we have root tips maybe 1 or 2 millimeters and trying to go fish after it, do you suggest there's a particular skill that one needs, or should they refer to an oral surgeon if they're a GP? What are your recommendations?
Yeah, in Italy the situation is different than the USA. For example, I have the bachelor in general dentist, but also I have the specialization in oral surgery. So I think it's very important to have a good knowledge about this surgical technique, for example, impacted teeth. So I suggest that it's very important the formation. So the general dentist is very important for the general dentist, uh, the continuing learning to increase your technique, because the oral surgery is different than the general dentist. So in case of the extreme surgery, for example, impacted teeth, I think is uh, is recommended uh, to send the patient at the specialist, at the oral surgeon, for example, because it's different. This is the different approach. We have um, two different dentists, general dentist and its general dentist that manage the simple extraction, for example. But in case of the extreme cases, impacted teeth, I think is necessary to have a oral surgeon knowledge, I think.
Yeah, I
And
agree. I agree with you, but there's so many teeth out there that there's not enough oral surgeons to do them. So
yeah,
it's it's good that the general dentists have the skill, at least to do most of the extractions and refer to ones that are more complicated.
yeah,
I've met all kinds of oral surgeons in my 60s. I'm a general dentist too. I've done tens of thousands of different wisdom teeth extractions, but I learned mostly from oral surgeons by watching them and gaining. It's a very big learning curve for the more
yeah.
complex wisdom teeth.
Because in the USA is different. The continued learning is more frequently in USA than the Italy. So I think in USA the formation is very high level, and I think the best former is our mutual friends, the Aaron Garg.
Oh yeah, Dr. Garg. He's a machine. A very very driven doctor. Very successful in his books and he's every day he's in a different city lecturing to different people. So
Incredible,
yeah,
incredible man. I respect him a lot.
yeah, Arun is sort of now the leading guy in the U.S. for dental implants. Vast majority of newer graduates end up in some program or another of his. So when do you take the time to teach? You're also doing you're also an adjunct professor over in Milan.
Yeah.
Uh, how often do you do that?
I go in Milan 1 day or 2 day every week from about 8 years. Many times. From 8 years, I work in Milan like consultant about oral surgery and like adjunct professor. So I spend part of my week between Milan and south of Italy in my clinic.
So, what kind of students do you have? Oral surgery students, or mostly?
General, the students of the dentist, general students about general dentist, and also there is the specialization in oral surgery. 3 years of oral surgery specialization. After 6 years of bachelor, there is 3 years post bachelor.
Excellent, excellent. So, It's similar here. We have 5-year programs, we have 4-year programs. Depends on, you have 6-year programs if you want to get an MD. It's all different. So
My dream it will be to work in USA, but it's impossible with my bachelor. But I love USA. I love American guys. I love USA.
yeah, we like you a lot too when you come lecture. You've been a couple of times here. You work with a lot of colleagues.
And especially I love California. I went in San Francisco in December and in October in Los Angeles, and those places are amazing.
Yeah, I'm here right now in California. I'm in Palm Desert,
Yeah, I know.
and it's always sunny here, you know. So
Lucky
you're
man for
welcome to come and do some surgeries with me. I had a colleague from Holland come recently and did some implants surgeries with me, and we documented the cases. So you're always welcome to come out. I get a lot of doctors that come through here to do shoulder training, that type of thing. What implant system are you using right now?
Sorry?
What implant system are you using? What?
Actually, I use the very new implant system, Israel and factory, AB implant. Do you know AB implant?
Yeah, I've
Brand
heard of.
system. Yeah, AB implant and also
There's
and
1,200.
also Ostem. I use Ostem and AB implant.
Awesome,
Actually,
excellent. Yeah. There's over 1,200 implant systems now, but I'm quite familiar with a lot of them. Um, Going to different offices, it's not the implant itself that's necessarily. It's has a lot to do with operator skills, because implants, you know, are composed of titanium mostly and zirconia, and they take. I mean,
I think the implant, the systemic implant is very important. The prosthetic tools, the prosthetic connection, the conical connection, I think is the future.
internal conical connection, yes, that's the newer version. Yeah, I have this discussion with Dr. Niznig all the time. He's a very good friend, and he started the patent on the internal connection. Was a hex, and then there's a lot of different derivatives from that. But still, the flagship of most implant systems, the internal connection.
Yeah.
So let's take.
Connection.
Go ahead.
No.
Come again?
I'm sorry. No. Okay. It's okay.
I wanted to reflect upon what you said earlier, and maybe we could take a few minutes here to discuss what you I see you often posting about this whole virus and precautions and things that should be done in the dental office now for the coronavirus situation. So maybe you can give our audience a little bit more of a rundown as to what your thoughts are in that regard.
Yeah, I think it's very important in this period in order to take care ourselves and our patient to follow the right protocol. The first step is very important to check the body temperature with the scanner laser. It's very, very important. And after is very important to washing the hands to reduce the possibility of the infection, because this coronavirus has a very high contagious. So it's very, very important to washing the hands and to use the protection to reduce the infection between the patient and the doctor. Use the gloves for the patient is very, very important. And I think in this moment is very important to reduce our activity only for the emergency. Because, for example, in Italy, the percentage of the infection patient is very, very high. So only reducing the infection, it's possible to obtain a good healing in the next month or in next week. So it's very important to reduce our activity, to reduce the patient, and it's very important to reduce the activity only for the emergency. It's very, very important. But I think the first step is to check the body temperature. It's very, very important because the classic symptoms of the coronavirus disease is the temperature about 37.5 degree upper. So it's very important to check the body temperature with a simple scanner laser.
So it's funny you say that, because we just got a notice from the California Dental Association that we should stop practicing, or at least stop practicing for non-essential treatment and focus on emergencies and cut down the days, because we are on the forefront of this thing. You know, it's the problem with this virus is it's airborne. It stays alive for a while.
Yeah.
And this airborne situation complicates things very much. What do you recommend on that scenario for masks?
I suggest that is very important to reduce the infection. The treatment of the area in the operating room is very, very important, because the virus is very resistant also in the next days. So it's very important to obtain a good quality of the area in operating room, and to clean the surface. Always clean the surface. It's very, very important.
Wow. So the problem also is that we don't know who carries it, because they don't have to be symptomatic. They don't show somebody carrying it doesn't show the symptoms. Could be days later or what have you. So yeah, I am personally myself reducing my day down to 1 or 2 days a week, and just seeing emergencies and people that I'm in the midst of treatment. But everything is shut down. I don't know what's going on in Italy, but you guys are in the center of it all. So tell us a little bit about that situation right now.
Yeah. Lockdown, because the infection is very, very strong. So it's in these next days, it's very important to reduce the numbers of the patient with the coronavirus, and it's very important to reduce all activities, not only dentists, but all activities, to reduce the infection, the contagious of the virus. In fact, all flights from and to Italy are stopped.
In Europe, yeah, you guys travel is being restricted too, right?
Yeah. In fact, I have many courses around the world, in Korea, in Moscow, in Kuwait, and all courses are cancelled.
Cancelled. Wow. Yep, I've seen that. It's even big conferences here are being canceled left and right. So
I saw you. You was in Hawaii with the implant of gag last week.
Yeah, coming back, the airport was completely empty.
Yeah. Congratulations for your lecture. I saw on Facebook.
Thank you. I'm working a lot on regenerative projects with experts from around the world, and we're looking at finding autologous solutions with PRP. You know, PRP is mostly involves growth factors and all the different signaling molecules, but we're missing stem cells in there, and I'm trying to find a way on how to harvest autologous stem cells, because you can do it now.
Yeah.
I don't know if you're familiar with cord blood stem cells from the umbilical cord. Some studies being done there. That's readily available through hospitals. But getting autologous stem cells is very hard because you have to go into bone marrow. There's not enough of it in the bloodstream, and the older you get, there's less and less. So it's a very, very challenging task. But we've done some research with cord blood stem cells, and to our surprise, the 3 cases we ran was very successful. Even treating cases like osteomyelitis and restructuring the bone, which I was lecturing on in Hawaii. But it should be an interesting time. They're harvesting stem cells from gum tissues, from the pulp of the wisdom teeth, and multiplying them and all that good stuff.
Yeah. In fact, I would like to learn the PRP or PRF approach, because in Italy it's not most common, and I haven't experienced, because in Italy there isn't a correct protocol. So in the future I would like to learn the correct approach in the USA.
Arun
Because
is
in
your
Italy
guy
there
for
isn't a correct. Yeah.
Arun is the man for that. He's the original. He's the discoverer, co-discoverer, and he's the guy. When you come out next time to the U.S., I would get in touch with him. But it's a very simple procedure. You draw the blood, you spin it down, depending on the setting of the machine, manufacturer recommended. Then you have PRP liquid, and you have PRP gel, and you can make membranes out of that. And healing is pretty phenomenal. Just in the first couple of days, you get a tremendous response because it's all your own, and then you can make sticky bone too. That's something that Arun also talks about, by mixing it gummy bone. There's a lot of things that you can do to facilitate. A lot of the bone grafting products don't necessarily always work, so when you have some autologous growth factors, your chances of succeeding are quite a bit high.
I haven't a big experience. In fact, I use in few cases on wisdom teeth. I filled the cavity with PRP, and I saw after the healing is very, very good, and is very quickly after the surgery. It's
That's
very,
interesting
very
you
good
mentioned that.
solution.
I have had 2 different kind of philosophies for old surgeons. You got the old timers that say, hey, the socket is going to grow from bottom up, and just leave it alone, let it be natural. Then you have the other group of oral surgeons that say, hey, you should bone graft the area. What's your take on this?
About the bone graft?
Bone graft versus not bone graft and wisdom teeth.
I think in some cases it's necessary to do the bone graft. For example, when we haven't a sufficient bone in the thickness and in the height. So it's very important to treat the reconstruction, for example, in the posterior area in a young patient, for example. In this case, I prefer use the autolog bone from the ramus of the mandible with Curie technique. I think is the gold standard using the autolog bone. Also, in other case, for example, in extended case, to increase the thickness of the soft tissue using the heterolog bone, like scaffold, to obtain a good volume, for example, after the extraction. In many cases, for example, when it's not possible to place the implant, in my experience, when it's possible, I always place the implant at the same time after the extraction. Not because the post-extraction implant reduces the bone resorption, but because it's possible at the same time place the implant, and it's possible to manage also the management of the soft tissue. So when it's possible, I use always the post-extraction approach. But in other cases, it's not possible to place at the same time the implant. So in this case, to avoid the loss of bone, to avoid the reduction of the volume, I use the heterolog bone like socket preservation to maintain the volume, not only the bone, but also the soft tissue. I think is very, very important. So the bone regeneration in many cases is very important, is necessary, I think, because after the extraction in the first 6 months, we have a loss of bone about 26% in the first 6 months. So it's very important to know this aspect, because after the extraction, we have a very loss of bone in the first 6 months. So if I haven't used the heterolog bone to feed the cavity, it's not possible to conserve the volume. So I think the guide bone regeneration using heterolog bone or autolog bone is necessary. But when it's possible, I prefer always autolog bone. I think is the gold standard.
I see.
And
So
with the autolog bone, with autolog bone, I think the one of the best technique is the Curie technique, because it's possible to obtain the 3D reconstruction, to split the bone and to using the bone chips to feed the cavity after skewed the bone graft.
I see. Also, it's good to put it in wisdom teeth sometime. On the lowers, often when I use the handpiece, and in your case, use the piezo, I put some bone in, and the chances of getting dry socket are very low. If you get good primary closure, you put the bone graft in. I don't have that kind of a problem anymore. Back in the day when I didn't do that, I used to get quite a bit of dry sockets, you know.
Yeah.
And dry sockets aren't fun. They're not.
Yeah.
What is your protocol on dry sockets? What do you do?
Dry socket is the one of the post-op post-op problems after the extraction. I think, and this is very important pain for the patient in 2 or 3% of the patient, but is very, very strong pain for the patient. In my experience, the treatment of the dry socket is not antibiotic therapy, because the dry socket is an inflammation, an inflammatory disease. So in this case, the only solution for the dry socket is the mechanical scraper of the bone to obtain a good bleeding of the cavity. So using, for example, the curette like Lucas curette, it's possible to scrape the cavity, to clean the cavity in order to obtain a good bleeding. And after, it's possible to reduce the symptomatology of a dry socket. But the antibiotic therapy is not necessary to reduce the symptomatology, to reduce the dry socket. So in my experience, to treat for the treatment of the dry socket, I use always the mechanical treatment with the curette and the use of putting the chlorhexidine at 0.2% to reduce the eventually sover-infection in the cavity. But it's very important to obtain the bleeding of the bone in the cavity to reduce the pain and to obtain a good vascularization of the bone to reduce the symptomatology of the dry socket, especially in the smoker and in the women. Is most frequent dry socket in the women and in the smoker, and in the patient with the particular systemic disease like diabetes.
Wow, that's good advice as well. That's one of the most painful complications that I have. Have you had a lot of any problems with paresthesia? Do you get that a lot? Have you had any kind of permanent damage, permanent numbing?
I think in the impacted teeth, the most frequently and the most important complication is not the injury of the alveolar nerve, because frequently the alteration of the sensitivity of the alveolar nerve is frequently transitory alteration of the sensitivity. But another complication is very, very important, the injury of the lingual nerve. So it's very important during the surgery to do a correct shape of the flap. For example, I use always triangular flap with one horizontal incision between the papilla, one horizontal incision of the papilla between the second or the fifth molar and the distal incision with the vestibular approach to avoid the lingual nerve, because in 45% of case the lingual nerve is more superficial, is a more superficial position, so it's possible in this case to injure the lingual nerve, and the injury of the lingual nerve is more dangerous for the patient, because after the injury of the lingual nerve, it's possible to do also the permanent injury of the lingual nerve. The patient had the alteration of the sensitivity of the tongue and the alteration of the phonation and on during the mastication. So it's very important to preserve the lingual nerve, because in the surgery of the impacted teeth is, I think, is very, very important to preserve the lingual nerve, because using the piezosurgery device, using, for example, also the coronectomy, it's possible to preserve the alveolar nerve. But frequently, using a bronch flap, it's possible also during the disconnection of the flap, it's possible to injure the lingual nerve. In this case, it's possible to do a correct protocol using the cortisone, using the particular drugs for the systemic disease, like alteration of the nerve to reduce the edema on the nerve and to obtain a good healing of the lingual nerve. So cortisone, B vitamin, and another drugs to obtain a good healing of the nerve. So I think it's very important the lingual nerve preserve in the approach of the impacted teeth. Usually, in case of the injury, the alveolar nerve, the healing of the alveolar nerve is possible to have after 6 or 8 months later the surgery. So frequently is temporary alteration of the lingual nerve, alveolar nerve, sorry.
I see. Very good. Well, that was a lot of information for somebody perhaps younger that has joined us, but you know, oral surgeons can really relay what you have said here today. So thank you so much for your time. I think this is great for us to be able to have this discussion with you, and perhaps we can have you back again with more updates on the whole scenario in oral surgery, because every year there's something new that comes out, new ideas, new protocols, and all of that. So perhaps you can help us with that information, Angelo.
Thanks for having me today, and I'm glad and honored to share my time with you, with all of you, also in this particular period. And I think the continuing learning is very, very important for our practice. And I think the Extraction Academy is a very excellent academy to increase our knowledge in oral surgery and in the extraction surgery. So thanks for the opportunity, and I hope to do next time another appointment talking about another topic like implant surgery or the oral surgery.
Yes, I thank you very much, and I look forward to having you back on the show. And have a great day.
Have a great day, and we stay strong.
You can beat the coronavirus. You can do it. Take care. Bye.
Bye bye. Be safe.